Good afternoon, everyone. I'm Terry Hill, and I'm the Senior Advisor for Rural Health Leadership and Policy here at the National Rural Health Resource Center. And we welcome you to another meeting of our National Rural HIT Coalition. I think the topic today is one of huge importance, which is care coordination for rural hospitals and clinics. Particularly the kind of the lessons learned and what we found out during the pandemic. So let me go over the agenda briefly, and then we'll begin with our programs. We're first of all, as we usually do, going to get an update from Nicole Clement and Jenna Cope in regard to TASC, our Technical Assistance and Services Center, the Federal Office of Rural Health Policy, and the Office for the Advancement of Telehealth. So there will be updates as we usually do. And then Neil Newberger from Health Tech Strategies, who's been kind of a collaborator and a co-chair of our group from the very beginning, is going to bring you the federal updates. He's got some slides he's going to share with you. And then our own Alyssa Miller, who is the Chief Operating Officer for the National Rural Health Resource Center and an expert in her own right in terms of payment models and care coordination, is going to be talking about the care coordination for rural hospitals and clinics. And then we're pleased to have Cheryl Vault from the Rural Wisconsin Health Co-op talking about successes and lessons learned during the pandemic. And, the Rural Wisconsin Health Co-op is a network of many hospitals and I think some clinics and other organizations in Wisconsin. So that's going to fill up our hour. And we're really pleased to have you with us today. And without further ado, I'm going to turn things over. Nicole, are you going to go first?
Yep, I'll go first. So just very few updates from TASC right now. We are wrapping up our program year, just like you guys kind of are here at the end of June. We have still 2 more webinars in the telehealth webinar series. One of them will be in the next couple of weeks, and then one in early August. We also have another HIT Coalition meeting coming up. Those things just aren't quite figured out yet, so save the dates have not been sent. In addition to those things, we also have a Flex Virtual Knowledge Group coming up and a TASC 90 coming up. So just watch your email for those save the dates to come. We also have the Flex Reverse Site Visit coming up. If you haven't registered for that, please make sure to go to the event page on our website, which me or somebody else will paste a link to here in a second, and get registered for that event. And I think that's it from TASC right now. So Jenna, why don't you go ahead with updates from the Office for the Advancement of Telehealth?
Oh, I apologize. I was on mute. It's great to be with you again. My name is Jenna Cope. I work with the Office for the Advancement of Telehealth at HRSA, and I am here. I'm going to also share some updates on behalf of Laura Seifert from Federal Office of Rural Health Policy. So just a few updates. The FORHP office, Federal Office of Rural Health Policy, just released a new NOFO, or a new Notice of Funding Opportunity. It was just recently released, and it is for Rural Emergency Hospital Technical Assistance Center. And with this funding, HRSA's Federal Office of Rural Health Policy will award up to $2.5 million for one national center that will provide expertise to rural hospitals in determining if the rural emergency hospital model is right for their community. And if it is, they will facilitate a successful transition. There is more on the Notice of Funding Opportunity. If you're interested or know of anyone interested in the grant, I will also post it in the chat so you all have a link. In addition, for the Office for the Advancement of Telehealth, if you haven't, the telehealth.hhs.gov website has posted several new toolkits. If they are of interest, please feel free to check them out. There's quite a variety that have been added in addition to videos. Just two more brief updates as well. The Center for Connected Health Policy has an upcoming webinar on June 24th about Medicaid telehealth policy and substance use disorder. I'll also post a link to that as well. That's going to be June 24th at 11 a.m. Pacific, 2 p.m. Eastern time. And then last but not least, we also have one of our TRCs, Matrix, also released a new implementation toolkit for transgender population, and it is now live. So again, I will post several of these resources so you all have them, but I think that is it for today. Thank you.
Terry, you're on mute.
Thank you. Thanks, Jenna. We appreciate your update here. Our topic for today, we try to always make sure that it fits into our Medicare Flex program itself. And I think care coordination really is such a huge part of care delivery. It's been absolutely important since the pandemic hit, et cetera. So I do want to make that connection to something very relevant to our Flex programs. I'm going to hand off now to Neil Newberger, who I think those of you that regularly have tuned in to our productions here know well. And Neil, what is happening from a federal standpoint in regard to our subject?
Thank you, Terry and Nicole, coming at you from a depth of 60 feet under the ocean where the existential threats of life are more easily dealt with. Promise not to take more than an hour for this. No, 5 minutes, Terry, you know that. So Nicole, maybe, or who can bring up the little slides I put together? I don't know, are they up there? Or?
I'll get them for you, 1 second.
Thanks so much. The first one, as I recall, has to do with a call for nominations to the High-Tech Advisory Committee, which was established under the Cures Act a couple of years ago and is set up to allow for patients and consumers and healthcare providers and allied health workers and technical types and things to make recommendations to the federal government for a term of 3 years, starting in January of 2023. That'll be this new round. And so it's an opportunity for all of you to get your oar in and nominate folks. And I would encourage you all to get together and come up with good candidates and things. Here is the link to the Federal Register announcement on that, and we especially want to help the department get the word out about that. Also, if you can spread the word, thanks. Next slide, please. So before I get to that, let me just say generally that there is a big push on to, either extend the PHE through the end of 2024 for purposes of the exemptions and waivers to the otherwise face-to-face Medicare requirements and all of the other related provisions and the emergency provisions that were put in place, 2.5 years ago or so. And the department is in the process of, evaluating where that's all at. There are calls for permanent telehealth legislation to be introduced and taken up in 2024. And we'll just have to see how that all goes. But that's, the big enchilada in terms of things that are on the radar screen of the national groups, the Connected Health Initiative, HIMSS, all the other major telehealth organizations and things. Whole bunch of regulatory filings at various agencies, especially around the edges, depending on what you're interested in. We don't have time to get into them, but know that there are filing opportunities coming up at NIST and at CMS and the Office of the Inspector General and the FDA and the Office of the National Coordinator for HIT and the various agencies responsible for implementing the Infrastructure Act in terms of broadband. And I'll mention that just quickly at the end in about a minute or two. Next slide, please. Or no, leave it there for a second. Thank you. Thank you, Nicole. So HHS has issued guidance on HIPAA and audio-only telehealth as of June 13th to cover how healthcare providers and plans can use remote communications technologies to provide audio-only telehealth services in a way that is safe and reliable and, within the bounds of HIPAA in terms of privacy and security of individually identifiable health information. And I encourage you to take a look at that at this link. Next slide, please. So a major issue to me and a lot of folks on this call, I think, is information security in healthcare and privacy over time as the technology becomes adopted even more in terms of millions of connected medical devices over inter and intranets and things. And so the FDA has been trying to keep a handle on it. And April 8th, they posted recommendations to increase cybersecurity of medical devices. And the bottom line from their perspective is that security needs to be built into the device and not bolted on after the device is designed, because the threats to healthcare sector have become more frequent and severe. And, we're just seeing that daily. I work with a couple of different InfoSec firms on healthcare issues. And oh my gosh, if you could see some of the things that we see in terms of the ransomware and denial of service attacks that are going on an ongoing basis, it would make your hair stand on end. At the same time as the FDA is proposing guidance, there has been legislation introduced by Senators Rosen of Nevada and Young of Indiana that would require HHS to review and update cybersecurity every 2 years. And that was introduced in June of this year. And we can get you more information on that, including the bill number shortly. Next slide, please. So here are just a few resources so that I don't take too much more time. And I encourage you to look at these links because they're trying to track all of these federal and state initiatives in terms of policy during and after the pandemic, okay? And so here's the link to DHHS's policy changes. Next slide, please. And here's a really good survey that is ongoing by Manhattan Associates that looks at federal and state level developments, including payment parity law updates and a whole lot more in a very easy to digest and searchable kind of manner. And so if you want to see what your state's up to, go to this link. Next slide, please. And the Federation of State Boards of Medical Examiners also has been looking at those states in terms of which ones have modified their regs in terms of state licensure, accreditation, certification, those issues, and reimbursement. Next slide, please. Been talking with John Windhausen, who's often on our calls to talk, to bring us up to date about the Connect Act and the USAC program and all the rest, which has, gotten a significant bump, as we discussed in our last call, by the in excess of $1 trillion infrastructure bill, of which north of 40 billion is going to be available for broadband, especially in rural and underserved communities, that being a major focus of HHS in everything that they do across all of their agencies. And so we've been talking to them a little bit, and we'll want to keep you involved in this, about how we can work with Shelby, focus more on especially the health aspects of this as it relates to all of the other issues and the kinds of ways in which SATCOM and fiber, even though it's not out there, I know in rural areas, and other broadband capabilities can be pressed into service for telehealth, remote patient monitoring, and all of the rest of the things that we've been talking about. And we'll let you know how that goes. But do have a look at Shelby's rural healthcare page, and we can get you other resources on where the FCC and the Department of Commerce, Department of Ag, and others are at in terms of implementing the infrastructure for broadband in rural areas for rural health applications. Next slide, please. That may be it. Oh, and then just one last link is the Center for Connected Health Policy, which is, as you know, the major HRSA funded resource center focused on, what's going on in the policy world. And here's a link to them. They've got some really good materials and additional links to where it's all at in terms of policy. I think that may be it.
That is your last slide. Yep, that's your last slide.
Okay. And I'm always here to answer questions if anybody has any. Look forward to the rest of the program. Thanks so much. I'll turn it back.
Neil, I have a question in terms of, the biggest pushback we ever get in terms of expansion of telehealth is the payment issue. Were you saying that the proposal is to extend this to 2024, which I think
It's a start, yeah.
Right. So in essence, do you have any just off the cuff analysis about, does this seem to have congressional support? Because I know you know Congress really well.
Yeah, no, I think it will. I think it's gonna, I think they're gonna be hard pressed to go back to the way it was 3 years ago, given what's going on. As I said, the department is doing an evaluation, and hopefully that comes in a way that is, supportive of the notion that we should continue as is. The one thing I worry about, Terry, is that, and I mentioned this, I think in the last call maybe, is that there has been some fraud, and we know that the Justice Department and others are looking at some of that, and that in and of itself can be a major showstopper, right? I mean, that could take us backwards if that persists. And so I think it's incumbent on everybody in the field to not just kind of run away from those stories, but to take them head on and show how in evaluations and in the literature, this stuff works and it isn't being misused, and it is adding additive in terms of efficiency and quality. But on the Hill, I think it just hasn't come up. There's just so much else going on right now that they've turned their sights to. So I mostly for now, I think all of the rural related groups led, and others need to get together and make sure when it comes up and when these various bills, and there are bills that would extend it by various lengths of time or permanently, that we're in a position to make sure we do the grassroots kinds of things that need to be done to help support it. That's a long answer, I know, to your question. But.
Thanks, Neil. Any other questions for Neil or on this topic of policy or federal updates? Okay, thanks a lot, Neil, as usual. Let me introduce our speakers now for this session. I'm going to introduce both of them at this time, and then we'll move from one presentation into another. Our first speaker who's going to talk about care coordination, as I mentioned, is Alyssa Miller, who joined the center in December 2013 and brings over, she's got about 10 years of experience in managed care Medicaid and Medicare experience. So she's kind of our go-to person in terms of payment at the center. Her experience includes care coordination, program development, quality improvement, and collaboration with local and state partners. She also, besides overseeing the operations of the center, Alyssa works with networks and rural communities to understand the critical components of care coordination and how it's an essential part of the new value-based payment systems as such. So she has a full plate of not only the COO act responsibilities, but is involved in a lot of other really important areas here in the center. Our other speaker who will follow is Cheryl DeVault, and she's an RN and the primary care program manager for the Rural Wisconsin Health Co-op. If you want to see a really, really good network or cooperative, look to the Rural Wisconsin Health Co-op. They've been around longer than any other networks in the country, and they're just such a terrific organization in general. She has nursing experience in inpatient and outpatient care, staff education and management in ambulatory primary care, oncology, and rural health care. And her expertise includes primary care quality and project management. She's responsible for managing collaborative quality improvement initiatives, and just a vast wealth of experience here that she's going to provide to this coalition. But with introducing both of them, I'm going to turn things over to Alyssa Miller. Alyssa, the floor is yours.
Thanks, Terry. And I'm just going to share my screen here. And I'll put it in presentation mode. And I'm hoping everyone can see the presentation mode of my slides. Can you see them, Terry?
Yes.
All
I
right.
can see them perfectly.
Perfect. So thanks, Terry. And as Terry mentioned, I'm the Chief Operating Officer here at the center, and I also have the extreme pleasure of working with many of our center programs and community outreach, engagement, and care coordination. Just a brief reminder, this project is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services through the Information Services to Rural Hospital Flexibility Grant Program. And for those of you that may not be familiar with the center, we are a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. And as the nation's leading technical assistance and knowledge center, we focus our work in the 5 core areas you see on this slide. The center is committed to building a culture where difference is valued and are committed to the diversity, equity, and anti-racism. So we create an environment that reflects the communities we live in and serve, a place where everyone feels accepted, empowered to be their full authentic selves, and where everyone belongs. Please take a moment to read more on our website for our full statement and what we are doing in this area. So I was asked to join your meeting today to talk about our care coordination framework and how it's an integral part of changes in care delivery and payment or value-based models that are affecting our rural health clinics, small rural and critical access hospitals. So the focus of today's conversation is how care coordination and the technology that is needed is to support their success in these value-based payment models. So this slide from the American Academy of Family Physicians states that in order to achieve the expected outcomes and performance required by value-based payment, primary care providers must review key components to providing quality care, such as delivery, care management, and care coordination across the medical neighborhood. And I'll be so as bold as to add the social and community neighborhood as well to that definition. So this visual may be one of the best ways to describe what's truly happening in the healthcare industry that makes care coordination so important. The iconography in the upper left is the current fee-for-service model that's based on volume. So payment system is really based on fee-for-service. There's very limited financial risk. There's limited communication between providers, limited focus on outcomes and information sharing. Care is often provided in silos, each doing their own thing. And so the upper right iconography is really focusing on that value, that transition to care coordination, that the ties between each part of that care plan, the delivery of the system, and that it is a key role in improving the communication and care of an individual and its population and its community. I threw this slide in just because I've been reading through this document, and this is an extreme summary from a document Rural Health Value produced It's an awesome document, really, that outlines payment models and programs by category, participation requirements, and the step or where it's at in the CMMI. It's called the Catalog of Value-Based Initiatives for Rural Providers. And I'm including this because even though it's categorized into 4 different value-based model types here on the slide, there's many different programs that are affecting our rural health clinics and hospitals, or that will affect or that could. And so the first category is fee for service. There's really no link to quality and value. There's some examples of this that from our, there's examples of this are like diabetes self-management training, and there's an emergency triage treat and transport program as well too. Number 2 on here, fee for service type models, where there's really a link to quality and value. You may have heard terms like the quality payment program. And so it's where foundation payments for infrastructure and operations are supported, like the accountable health communities model you may have heard of, pay for reporting and pay for performance as well. Advanced payment models, where they're really built on the fee for service structure, but they are tying more in upside rewards only for appropriate care. And another type is where they're including upside and some downside reward for appropriate care. You may have heard of Medicare shared savings programs, for example, as well. And the 4th area that I'm really excited about and have been diving more into is population health-based payments, specifically around condition-specific population-based payments, comprehensive population-based payments as well too. On condition-specific population-based payments, you may have heard of bundled payments for care improvement. Under comprehensive population-based payment programs, you'll have heard of accountable care organizations. There's a new one, REACH, ACO REACH, that I'm starting to learn more about as well too. And I provide those examples because there's many of them, but at its core, care coordination is a huge part of these payment models, and that it's for our providers to really start to think about and focus on care coordination for those improved population health, to be successful in these models. These next few slides that I'll be sharing with you will focus on what care coordination is, a tool for organizations to use in planning for their care coordination. And I'll also share how this tool addresses technology as a key foundation for their coordination work. So care coordination is the concept of connecting persons with healthcare professionals to ensure that health needs are being met and that the right person is delivering the right care at the right time and connecting to those needed community resources. It empowers the person by bridging the clinical and the community they live in by looking at the whole person. We start with the individual, and collectively it rolls up into the population for improved population health. So care coordination is huge and ever changing. And before we go any further, I want to provide you with some definitions that we have dove into over the years. You'll see words outlined in bold on the screen, and they're common words that connect the importance of these very different industry-specific definitions of care coordination. It shows that they have some shared commonalities with what care coordination is as well. You'll see words like patient-centered, coordinated services, clinical and non-clinical, prevention and management, and social aspects. As we continued at the center to work in care coordination, we saw that community outreach and engagement was becoming key. This definition is taken from Stratus Health and is focused on community care coordination that addresses population health. So this is where we focus on collaboration among healthcare professionals, clinics, hospitals, specialists, pharmacies, mental health, community services, and other resources working together to provide that person-centered coordinated care. Kind of go back to that iconography in the upper right category or corner that I showed you too, because as a healthcare industry, we're much more naturally looking at clinical related partners such as specialists and pharmacists, but it's not as natural to look outside of our walls to the community services and resources that can work with us to improve our population's health. You know, we really need to look beyond our clinical walls as well. So how do rural health clinics, small rural and community, critical access hospitals to begin to prepare for community care coordination? We created this Canvas guide in this tool. And about 8 years ago, Deb Blaine, Terry, and I began working on really studying different care coordination and case management models. And the intent of this study was to support rural networks in awareness of and understanding what emergency care coordination models are. And over the 3 years since we created that, in about 8 years ago or so, we saw that care coordination was really changing almost as fast as technology. And so in 2017, we updated these materials, and the finished product of this is this care coordination guide. And so this tool we often use when working with organizations for them to start thinking about care coordination in their organization and outward. So with this information gathered in this study, it was very clear to us that there are 4 common components: target population, assessments, care team, and care plan. The tool, the care coordination Canvas tool, was developed based upon the center's experience developing the guide. And so originally it was designed to help organizations, like I mentioned before, to develop their initial care coordination efforts. But we soon found how organizations with mature and well-developed programs were using it to evaluate their current efforts as well and to improve upon that. So we also use this Canvas to set a foundation of what we mean when we're talking or when we're utilizing terms, programs, or processes in care coordination model. We use it to put a common language together for what when we're referencing care coordination with the organizations. It's a tool that's adaptable to any situation and has multiple uses. In fact, Terry and I and some other coworkers are using this aspect to help in another grant program to guide a development of a community paramedicine program as well. So like I mentioned, there are four areas of success care coordination model. And so this tool walks through 4 quadrants or components of the care coordination canvas. So we have that target population, and I've got another slide that will kind of go further into these areas, but it's a really strategic kind of framework to help them think through their model as they're setting it up. The second, the upper right, is that assessment component or the tools that they would need. Then we have the care plan aspect of it, and then the care team. So in addition to those 4 components to the canvas in our tool, we found that there are 2 additional elements that are very critical for success and that are integrated into each of these 4 components, and that's communication and technology. So how will you communicate with the person, the care teams, and how we use technology to be your support in your model in order to do this work? And lastly, in this framework, there are 2 other considerations that we bring forward and for a successful model, and that's collaboration. So care coordination is the key for value-based models, but then collaboration is the key to effective care coordination. So who else do you need to collaborate with to ensure improved health of the population you're working with? Because as we now know and understand how social determinants of health play a role in health outcomes as well. It's all those things that affect a person's health beyond just access to the clinical care that we have to incorporate into our work as well. So I want to take a look at what's happening in each of these quadrants and how we approach it, and then how health information technology plays a role into it. So the target population is really improving the care, health, and reducing costs for a specific group of people. When we think about technology, as we begin using this tool, we ask questions about how will technology be used to perform the functions necessary in this target population. So how will you use your electronic health record to shift through the medical records to identify what population, what chronic disease needs help or needs care coordination. Are you using payers claims data? Are you part of an ACO where you have access to payers claims? So how are you going to use technology to support that mining? Disease registries, capturing referrals, and so forth like that. So really in our guide, we ask them to think through all of those needs, interfaces, things like that. And then how will you communicate with and engage the population? Neil spoke to us about many opportunities with telehealth. We're starting to see telehealth incorporated into care coordination versus in-person and or telephone as well. So how will you communicate? How are you going to use the portal? How are you going to use email? Are you going to, like I mentioned, telehealth, text message, so forth? The assessment box is a tool or a survey. It really walks them through that it's a tool or a survey used by the coordinator to assess a person's level of need clinically and socially. It's used to determine those social, environmental, mental health, physical, and psychosocial functional needs. It can also determine the risk or severity level of a diagnosis and or disease. And so when you think of some of those payment models that are addressed towards readmits, hospital readmissions, high use of the ED and so forth, you can use different assessment tools to help identify those triggers for those and impact that. So when you think about technology and communication, again, how are you going to use your electronic health record, interfaces, other technology to communicate, to not only communicate the results of the assessment, but to maybe do the assessment as well too? Is it a questionnaire in the electronic health record? How are the scores of those risk assessments shared with your care team and so forth? These are just examples. And then you have the care plan, which is an individualized plan of care that's developed with that person and or caregiver and the providers to identify those person's needs. It then creates an approach to help meeting those needs. Is the care plan developed with the person? So some questions that we ask: how are you going to develop that care plan with that person and family and that clinical team? What's included? You know, there's many important components that are listed in the guide, and you can go into that. We don't have time to go into it. But how, again, oops, excuse me, I get trigger happy, or my fingers gets clicking. But how will the care plan, once it's developed, be communicated with the person so they have a copy of it? How will you share it with the care team? You know, I was recently working personally with my care team, and they're going to still fax the care plan over, you know, we know that is still a reality, but how can we use connect the different electronic health records and so forth, or use secure messaging as well? And then we have the care team. And so this is the providers, both clinically based and community based, identified with that person and caregiver that represents all of their needs. So the clinical, the behavioral, the social services, long-term care, and community resources needed to help meet that person's goals and outcomes. And so we think about ways, the care plan's developed. How are we going to alert the entire care team that there's been an update to that care plan? How are you going to do that? Is it email? Is it providing them access to the portal, the electronic health record? Is it secure messaging? Because it's not only about creating the document and sharing the document, but how do you communicate updates as those needs arise? So I mentioned that we have a guide for this. This slide just provides you links to where those materials are. This is a screenshot of our website and the actual links. We also have a video that helps walk through providers through this educational tool and resource. I'm just going to give you some very high level challenges that we've experienced, because Cheryl's going to go deeper into this, particularly during the pandemic. But there is extreme challenges in workforce, particularly dedicated staffing to do care coordination right, and that it's a primary part of their job. Also, many in our small rural organizations, our staff wear multiple hats, and so having the dedicated time to be able to do this is an extreme challenge. Reimbursement for care coordination is coming along, but it's not all the way there yet. And so reimbursement strategies, at least up front, to get all of this work done is a challenge. You know, it takes time to set up those, to understand where the need is, where to start the care coordination, the planning, and how to develop those systems and workflows, which IT is at the heart of it. Particularly, it's expensive, especially when you have multiple providers and organizations on different platforms. But it's necessary to do this upfront thinking and planning for those successful care coordination models. And so, you know, I went fast, very high level, but care coordination is truly a key that unlocks the door to those successful value payment models and to a healthier population. Here's my contact information, and I will stop sharing and hand it over to Cheryl to really dive into more of those challenges that providers and networks are seeing, particularly in the pandemic.
Well, it's just a
Cheryl?
comment. First of all,
Sure.
I just want to compliment you that both on the tool and in your presentation as well. You know, people get caught, patients get caught between the many silos we have here. So I really appreciated the fact that when we started looking at a project with community paramedicine, Melissa was able to bring over that tool so that we thought of all of those components as well. So when we're in silos, as I said, people get hurt and there are breakdowns, et cetera. So I also like how incorporating the technology needs here is not only important, but I think we need to make sure that any of the technical stuff gets integrated into the actual care of patients and ensure, just a smooth flow of patient care across the various dimensions. So thank you for that. And Cheryl, we'll turn things over to you.
All right, good afternoon. And you have my presentation up on the screen. You should be able to see that clearly, I hope. Is it up there?
Not yet, no.
Not yet.
It's your document drive.
Let's do that again. My apologies.
Okay. There it is.
Okay. All right. So I was asked to present on successes and lessons learned with the care coordination during the pandemic. And as Terry mentioned, I am from Rural Wisconsin Health Cooperative. I work with Lewis Wenslow and Tim Size. We have been a part of the Rural Wisconsin was incorporated in 1979, and we work with 44 of our member hospitals that they own us and we work with. So going back to this really quick, I just wanted to share, Deb Lane reached out to ask the question about this, and I provided some information, and I think that's how I was asked to be a part of this. I was sitting here trying to think how that even happened. I started working with Deb Lane about 5 years ago.
Cheryl, just an FYI, you're showing your presentation mode screen versus the full slide.
Let's see. Is that there? Now it is? Oh my gosh, I don't know what's going on here. Let's see, share.
Perfect.
Perfect. Yeah. Okay, I don't know what happened there. Okay, thank you. So 5 years ago, worked with a grant, started with Deb Lane. We had 10 organizations. I had come from the UW hospital and I worked with care coordination. I said, I think this is a natural progression to primary care initiatives. We reached out to other organizations and applied for another grant, and now we are working with 19 of our member hospitals, and these are just a few that we are working with on care coordination services. When we asked our groups, like, why do you think we should be doing these services? We heard the same thing we heard 5 years ago, and we asked the question, it's good patient care. Patients need an advocate to navigate the system. It's going to help reduce hospital readmissions, increase access, unburden providers, and help patients make a connection with services. When we asked them about their barriers, it was money, time, lack of experience, staffing issues, approval to hire someone to do the work, so much going on in their organization, COVID-19 pandemic, and trying to bring all the resources together. The two that are stressed over and over now are the staffing and the COVID pandemic, obviously. So I wanted to touch on the staffing issues related to the pandemic. We knew already that before even going into the pandemic, that staffing was going to be an issue with the baby boomer generation already planning on retiring. And then our silent generation, they were already closing out their very lengthy careers as well. And a lot of them came back during the pandemic, thank goodness. So we had the short staffing, people were taking leaves of absence, staff were out ill taking care of their family members. There were childcare issues. We had traveling nurses and locum tenens and trying to get them onboarded to what they should be doing in our organizations. We had people that might have been doing care coordination in the beginning, but organizational leaders felt, you know what, that wasn't needed at this time. Let's get them working to higher acute needs. As we know, high patient census, high patient acuity, that led to patients delaying care and coming in with advanced illnesses. We're really seeing that this long-term effect now, even more so. We also had the issue of trying to figure out vaccine storage, the distribution, the COVID clinics, figuring out how to do monoclonal infusions and where to go for these. So a lot of the stuff was put on hold. The pandemic just exacerbated the issues with staffing. But we're really proud of things that we changed here at rural Wisconsin with our services related to the pandemic. With the issues that our members were already facing, we also thought about this as an opportunity to improve some of our services. Usually for our services and listservs, we provide, there's a cost to it because we need to keep our doors open, right? But during this time, we felt it was important that we create a COVID and a telehealth listserv to assist with communication and a place for our members to come and ask questions, get updates, and get the real-time information. Tim Size, I became the COVID queen bee here at rural Wisconsin. I don't know if it was from my nursing background or my can-do attitude, but boy, that was an interesting time and still is actually. We have roundtables here. Currently we have 45 roundtables, including care coordination as one of them. And our in March of 2020, when everything was happening, we decided to change all our roundtables to a Zoom format. So they were always had the opportunity people to be in-house coming to RWHC, and we had a few people that were way far in northern Wisconsin that would attend via Zoom. But then we changed that whole Zoom format. Now it's a hybrid form option, but it's a real flip-flop. We have maybe only a few people that come in person and all the rest are still Zoom. Our senior leadership team also recognized the importance of, during this crisis time, that we needed to increase the communication and opportunities for our members. So we opened up our roundtables for a 3-month period for members that if they didn't have someone on that specific roundtable, they could come and trial it for 3 months and use the listserv and all the resources. So not only did that promote our roundtables, but it also helped our members. We are very fortunate here in Wisconsin. We have the Wisconsin Healthcare Emergency Readiness Coalition. We call it the HRSA. When the COVID pandemic really started rearing its head, some of our members had no idea what the HRSA was. I went to one of our board meetings and some people are like, oh yeah, we use them all the time. And some of our CEOs are like, I don't even know what you're talking about. So again, we really became involved with there's 7 coalitions in the state of Wisconsin. I attended those meetings so we could get that information out to our members as needed. And the one thing that we are extremely proud about is the HRSA Care Coordination Grant. We started that during the pandemic. We might have started about 3 to 4 months late, but we made it happen and it's still going today. As I mentioned, with the grant here, we have 19 members that are currently participating in the HRSA grant, and it started during the pandemic. 10 out of the 19 organizations implemented and or optimized care coordination services during the pandemic. That's over a 50% success rate. That's huge. And when I say care coordination services, I'm talking about chronic care management, We had an organization, not only did they implement chronic care management, but they also implemented it with their palliative care patients. We had organizations start working with their social workers, pharmacy, diabetic ed, nutrition, and pulmonary groups. They implemented transitional care management, optimizing with swing beds, nursing homes, and other like assisted livings. They implemented and optimized Medicare wellness visits. And that was kind of huge, especially during the pandemic. But those calls and the telehealth visits were super helpful. And then advanced care planning. That was a big issue, as we all know, as we see people, they were, at end of life sometimes in the hospital, and we didn't want to have that happening. So it was a lesson learned. The other thing that we were very proud to implement is our Rural Wisconsin Chronic Disease Toolkit. We worked on this back in 2018 with Deb Lane, and we had that published, and we updated that in 2022 with a whole entire section just for care coordination. So we're very proud of that. That's available on the HIP exchange, but we also have it right on our Rural Wisconsin website, so any of our members can, or anyone can have access to that. So I want to tell you, this is just one organization that was never doing chronic care management at all. We started working with them. As you can see, in September of 2020, they had 0 patients. And look at that trend line that keeps going up for this organization. And this was during the pandemic. They're well over that now, as we are already in, I don't know what, June? Hey, it's first day of summer, that's right. So that is a success. You multiply those patients, they're getting best patient care, they're capturing revenue that they were leaving on the table. Here's just another organization. This is one way that they're showing the return on investment despite the pandemic. So even during the pandemic, they've been tracking their Medicare wellness visits, transitional care management, chronic care management. And as you can see, we have this automatically, so we can show the revenue that they earn, patients captured, their all-inclusive rate, revenue opportunities are missed. So this is a great tool that we work with our organizations to use when they're going to go and talk with their CEOs. Okay, so as I showed Lewis this presentation, I said, you are important. Information technology, it's so important. When I do a lot of Kaizen events where I go and work with organizations, I'll be doing one this week with a Northwestern hospital. And when I have the people at the table and IT representatives have to be there, they always ask, why do we have to be here? This doesn't even affect us. I guarantee you, they're the ones that are leaving with the biggest list of to-dos, and they're the ones that are talking the most to give us information. So it's fantastic. We had to change how we delivered care during this pandemic. We had to find opportunities to change how we delivered care to our patients and families. We even have some that are doing chronic care management via Zoom. They have some good broadband where that area is, but they're able to do it. We're figuring out ways to coordinate the data that's needed for the Wisconsin EMR resource reporting system. That when the pandemic started, it was voluntary to report their data, but then it became mandatory. So that's where that came in to talk about how many, what is the capacity? Do you have hospital beds? How many patients do you have waiting for skilled nursing facilities? It was all of that data that was being requested by the state. We also worked on interfacing the immunization registries, and that was extremely important with our vaccinations with COVID, and as well as pneumococcal and influenza vaccines. Figuring out how to do the non-face-to-face interactions, and that's typically how chronic care management is with a non-face-to-face. Virtual care despite broadband issues. Our IT people had to help us assist in setting up remote work areas. Looking at ways to deliver care for long-term effects of COVID-19 and increased mental and behavioral health issues. And continue to look at ways to implement or optimize team-based care, such as care coordination. Okay, I flew through that because I knew I only had a few minutes. So I hope that was helpful. My contact information is there. As I said, I do a lot of presentations on care coordination. That's a very big passion of mine. I just used the care coordination canvas tool that Alyssa was talking about. I just presented that to the North Dakota Rural Health Group last week with Deb Lane. I'll be using it this week. It's a great tool. I can't stress enough to use it and how to incorporate IT with that. And that's all I have.
Sure. Yeah. Thank you so much. Any questions for the speakers? I really refer you to the, not only to the slides, which we can make a copy of and make available to you, but to the resources that are available. So I also want to acknowledge Louis Wenslow, who's been a member of this coalition from day one, actually. So you guys are really fortunate to have somebody like Louis. And of course, Tim Size is certainly an extraordinary leader in that regard. I'm going to thank everybody for being part of this discussion. Nicole, any last words or anything before we wrap up?
Yeah, Patricia, would you go ahead and launch the exit polling, please? Thank you, everybody, for joining us. Like Terry said, definitely check out the resource that our speakers were talking about. We absolutely will include a copy of both of those presentations on the website with the webinar playback. And when we send out the recording, we'll also send out a direct link to that resource because it's a really good one. So thank you so much, Cheryl, who was referred to us through Deb Lane, as she mentioned a couple of times. And also Alyssa came to us by Deb Lane as well. So special thanks to Deb Lane, who is not even here to hear it. Thank you, everybody. Have a good day.
Thanks, Nicole.